Good afternoon. Thank you for joining us for today's webinar. My name is Marla Kaufman, and I'm the Communications and Health Promotion Coordinator at IHRP. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar via two methods. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Dr. Andrew Tatarsky, is going to answer questions periodically throughout the webinar. Again, you can submit questions anytime throughout today's webinar, and we will relay them to Dr. Tatarsky. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. You can also request a general certificate of attendance at no charge. Please take note that it will take up to 48 hours for your CEUs to be available in your My IHRP profile because we have to cross-check your attendance on the webinar. After the webinar, you will receive several follow-up emails. The first will be an email with a link to the evaluation. The second will have information on how to access your certificate of attendance and continuing education credits through your My IHRP account. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter, Dr. Andrew Tatarsky. Andrew Tatarsky has developed Integrative Harm Reduction Psychotherapy, IHRP, for treating the spectrum of risky and addictive behavior. IHRP brings psychoanalysis, CBT, and mindfulness together in a harm reduction frame. The therapy has been described in his book, Harm Reduction Psychotherapy, a new treatment for drug and alcohol problems, and a series of papers. The book has been translated into Polish and Spanish. He holds a doctorate in clinical psychology from the City University of New York and is a graduate of New York University's Postdoctoral program in Psychoanalysis and Psychotherapy. He is founder and executive director of the Center for Optimal Living in New York City, a treatment, education, and professional-based training center based on IHRP. He is a founding board member and twice past president of the Division on Addiction of New York State Psychological Association and member of the medical and clinical advisory boards of the New York State Office of Alcoholism and Substance Abuse Services. Andrew has trained individuals and organizations in 18 countries. His writing, teaching, clinical work, and leadership aim to promote a re-humanized view of addiction and a harm reduction continuum of care that will extend help to everyone who needs and wants it, wherever they are ready to begin their positive change journeys. He is also self-published. Okay, Dr. Tatarsky, if you are ready, I will hand things over to you. All right, Dr. Tatarsky, we cannot hear you yet. We can see your slides, but you're still on mute.
Mute.
All right, we can hear you and see you now.
Okay. Well, thank you very much. Sorry for the slight technical difficulty. So I wanted to thank Jessica and Christy and IHRP for the opportunity to present my work. I'm really excited to be here. We have a really large group from all over the country, so that's really gratifying to me to have an opportunity to share my life's work with a large group of interested folks from around the country. Just briefly, I've been a psychotherapist on the front lines of the addictions field for my entire career. And I've been grappling with the question since early on in my career of why have we been doing such a poor, limited, and problematic job of supporting people with problematic substance use and other addictive issues. And that's really been something that has been tremendously concerning to me. And I think in the current context of our overdose epidemic, it becomes even more glaringly important for us to think about that. What I've really come to believe more and more strongly is that um, there are really dominant traditional ideas about how we understand addiction that are really problematic and I think in many ways wrong, and that these ideas have been largely responsible for our failure to effectively help the overwhelming majority of people that struggle with these issues. And what I've come to through a series of interesting moments in my career um, is to believe that we need to shift the paradigm, what I call come to a re-humanized understanding of what we call addiction, from disease to what I call a psychobiosocial process model. And that shift in paradigm, shift in thinking, really supports a shift from a traditional abstinence-only disease model-based approach to treatment to what I call integrative harm reduction psychotherapy. And while, I call it psychotherapy and it really emerged out of a psychotherapy context, I think the work that I'll be presenting to you can really be adapted to every helping relationship. And so if we could think about psychotherapy or therapy in a very broad sense to really refer to helping relationships in a number of different contexts that could have a potentially therapeutic or healing impact. So in this brief presentation, I'm going to present a body of work that I've been really developing over 40 years, and that we now train folks in intensive level 1 and level 2 trainings. So that over 15 and 30 hours. So this is really going to be a brief introductory taste, which I hope will whet your appetite for more. And as was said in the intro, if you have questions that come up as I go through, please put them in the chat and I will stop periodically to check in. I also want to say that paradigm shifts can be really difficult to move from one way of thinking about things to another very different way of thinking about things. So some of these ideas may be very provocative or challenging or problematic for some of you, as they have been for me in my own developmental process. And I would really invite folks to share the questions, the concerns that may come up for you, or questions about how you may adapt some of this to your own settings. So with that, let's get started. So I believe that we need a scientific revolution. And in fact, I believe that we're in the midst of a scientific revolution, and that this paradigm shift that I'll be talking about reaches the level of a scientific revolution. Thomas Kuhn wrote a wonderful book called The Structure of Scientific Revolutions to talk about the very complicated process that happens when old ideas begin to sort of not really adequately explain or address dominant issues, and new ideas come up that seem to better explain and better respond to the needs. And it's in that framework that I think this work exists. So let's think about what the problem is that we are here to try to solve. We know that rates of substance use and unnecessary lethal overdose have been rising precipitously over the last 20 years and more dramatically over the last 6 or 7. Through May of 2020, and that's not even toward the end of the last year during this pandemic, we've had 81,000 lethal overdoses, which is a dramatic increase from the last year. And if we think about problematic substance use on a continuum of severity, including binging, heavy use, and full-on substance use disorder, both the federal government and private organizations estimate that we've got 100 million Americans who struggle with substance use that has some negative impact and public health consequences. And I really think that context is tremendous proof that our dominant addiction narratives of disease, stigma, and criminalization are ineffective and contribute to the problem. These narratives are expressed in limited support for effective care. That is, we both have limited effective care, but we also have limited support, to make effective care available to people across this country. And stigma is really woven into the fabric of our culture. We might think of stigma as being institutionalized. And then we have this failed overemphasis on prohibition and the war on people who use drugs, which I think has been one of the greatest harms associated with drug use in this country. So what might be a solution? And as was said, I think we need to shift our narratives, our understanding of people who struggle with drugs, of problematic drug use, away from disease toward what I call a psychobiosocial framework, and thinking about drug use and other addictive and problematic behaviors as health and human rights issues. And this paradigm shift will contribute to a whole, what I call a social revolution, that is, a change in the way that we have institutionalized stigma toward viewing people in a more compassionate, more supportive way, and in a way that is more true to their experience, that can be the basis for being more helpful. And I really believe that a harm reduction frame, a set of principles that we might call harm reduction, which I'll be defining for you, is really essential to that model shift. So let's think about how we can shift from a culture of stigma to one of compassionate pragmatism. That's the philosophy that Alan Marlatt, who was a giant in the addictive behaviors field, said he believed was at the heart of harm reduction practice. That is, compassion is what drives our wish to be helpful. And the pragmatic piece is that we need to be continually examining our principles, our policies, our practices, our therapeutic technique in a moment-to-moment way to look at what's working and what's not working, so that we can really be continually adjusting to what works, rather than be stuck in ideology. This has been expressed at a global level in a shift from thinking about moving from a supportive approach to people who struggle with drugs or people who use drugs, rather than a punitive, punishing one. And we're seeing a shift in emphasis, often away from incarceration toward making treatment available to people. I think that's part of this paradigm shift. And we need to really think about a complete continuum of care, linking education, prevention, public health, medical, mental health, addiction, and social services, linked by harm reduction principles. And I believe, and this is something I've been coming to more recently, but that we need to be shifting toward decriminalization and ultimately to legal regulation of drugs in the way we do with cigarettes and alcohol, because prohibition itself creates tremendous problems with a poison drug supply, with keeping people afraid to come forth and ask for help. This is something I'll be touching on a little more later. So I want to set the stage for this webinar by sharing a little bit about two patients, just very brief vignettes that I think illustrate some dynamics that are present for the overwhelming majority of people that struggle with drugs and other addictive behaviors. Valerie is a mom with two kids. She came to me a number of years ago reporting that she was injecting Dilaudid, which is a powerful synthetic opioid, 4 to 5 times a day. And she had been doing so for several years before she came to see me. Now, on the one hand, she said that she loved injecting Dilaudid. On the other hand, she was acutely aware that her drug use was putting herself, her family at great risk, fearing that if she was discovered, she might potentially lose her kids. She also felt that, having to hide, having to be preoccupied with her supplies, was a tremendously stressful, anxiety-provoking part of her life. And yet she seemed to be caught in this tremendous dilemma. And on the one hand, she loved injecting, and on the other hand, it was creating tremendous risk and tremendous harm in her life. So the issue that we identified that we could work with or needed to was, why did she love injecting Dilaudid so much that she would put everything else in her life at risk? Peter, and that became the initial focus of our work together. Peter was a professional who came in with a similar kind of story. He came in what he described as being in a love affair with crystal methamphetamine. And he was engaged in multiple days of binging on crystal meth with multiple partner sex, with anonymous sex partners. And he also had this experience of being in this love affair. Even while alongside of that, he was very well aware that he was taking great health risks. He had an increasing number of very frightening encounters with people who were using drugs and becoming psychotic and violent. He knew that inevitably, if he continued this, it would impair his health, his ability to function at work. And yet he was also caught in this kind of dilemma. And what I'd like to suggest we think about is that the overwhelming majority of people who struggle with problematic substance use are caught in some version of this dilemma. And so the question becomes, how do we understand this, and how do we help people kind of find their way out of this very painful spot that they feel stuck in? So I want to say a bit about what harm reduction is to make sure that we're all on the same page. And this is the definition of harm reduction from the Harm Reduction Coalition, which is the national advocacy organization that's been around since 1996. So this is their definition from 1996. And you see, they describe it as a set of practical strategies and ideas aimed at reducing the harmful consequences of drug use. Strategies and ideas. And harm reduction incorporates a spectrum of strategies from safer use to managed use to abstinence to meet people, drug users, where they are, addressing the conditions of their use along with the use itself. So this is really an interesting statement because, first of all, I think it challenges a misconception many people have that it's either harm reduction or abstinence. What this really highlights is that harm reduction is a framework for supporting positive change that really bridges across the positive change goals, including abstinence as one viable harm reduction outcome for some people. Another thing that I think is important here is that we're not just talking about drug use per se, or one's practices, one's relationship to drugs, but the conditions of use. So it really thinks about drug use, or suggests that drug use is best understood in a systemic context. And I think that's part of my thinking around psychobiosocial, which I will say more about. Also, harm reduction is a movement for social justice built on the belief and respect for the rights of people who use drugs. And this is so critical because of, the historic stigmatization of people who use drugs. And that harm reduction really arose initially, as many other social justice movements did, to support the rights of disenfranchised folks, when the dominant culture was not supporting those rights. So let's think about the harm reduction principles, those ideas, as a kind of frame that frames the way that we set up helping relationships. Compassionate pragmatism, I mentioned before, is kind of a core philosophy that's embedded in harm reduction practices. We might think of harm reduction practices as compassionate pragmatism in action. Now, this is the core shift, I think. this idea of any positive change, that is, that we aim to support people in reducing harm or in making positive change around their drug use and related issues without requiring abstinence, or even more radically, without imposing our agendas or values on the people that we're trying to be helpful to. I think that shift is a really dramatic shift from former traditional practices. And we might think about that as really ensconced in radical acceptance. That is, we may not like or agree with or feel good about certain people's practices. But if we're going to have any hope of being helpful, we need to begin with a radical acceptance of the reality of where people are and where they are in their lives and who they are. And that, I think, really opens the door to working with people across the spectrum. Now, this really enables us to meet people where they are. And we can meet them around the full range of positive change goals that fall under that harm reduction umbrella, around stages of change, all stages of change, which I'll say more about a little later. And what this is going to do is it's really going to reduce the threshold for engaging people. That is, we will lower the threshold to wherever people are able, ready, and wanting to begin their process of positive change, rather than requiring and demanding that they sort of overcome the threshold that we set. So it's really about working from where people are. And now, beginning where people are as unique people in unique circumstances, we can really work to tailor our interventions or what we have to offer uniquely to who people are. And we can work, the values, I think, that make that possible are that we meet people without judgment, without our own judgments, foisting our judgments on them, and grounding our listening and our presence with them in an empathic kind of attunement. And that then foreshadows kind of some therapeutic, the therapeutic, I think, expression of harm reduction, which is kind of an empathic listening stance, which I will get to when we talk about some treatment techniques. And we're shifting from this quantum change, that is the expectation of abstinence or expectation of jumping from where you are to where we would like folks to be, to thinking about change in more of a gradual, small, incremental way, a process. Change is a process. And isn't this also the way any complex behavior typically changes? So if we meet people where they are and we begin to help people identify small, doable, achievable, positive change goals, we can then support them in a process of working toward reduced harm and increased quality of life. And finally, the relationship needs to be guided by principles of compassion. Collaboration is really a core feature of harm reduction helping. And I think we might think about collaboration as being inherently empowering. So we want to support people in kind of getting in the driver's seat of their process of change around their problematic and risky behavior. And we work as a therapeutic team to walk with people toward their goals and in a way that they define as meaningful to them. Now, I want to just say a few more things about that. Most people think of harm reduction in terms of its public health applications, honest drug education, overdose prevention with naloxone, opiate substitution treatment, the Good Samaritan law, which is, the law that if you are with somebody who is in trouble, drug-related trouble, and you call the police, that you will not be subject to arrest and prosecution. Now, this is available in some states and not in others. In terms of substitution treatment, of course, methadone is the oldest, most effective harm reduction medication. Buprenorphine, Suboxone is a newer medication, which is also available. Now, this may be controversial to some, but in some places in Europe and in Canada, heroin maintenance is available and has actually been found to be very effective for people for whom methadone and buprenorphine have not been helpful. And even in Switzerland, there's been some work around morphine substitution, particularly with people who have co-occurring psychiatric issues. And it should be said that all of these interventions, syringe and needle programs, and even safer consumption sites, which are available in many places around the world, but not here in the United States, are all associated with dramatic reductions of overdose, of addiction, and increased entrance into treatments of all kind. So the public health harm reduction interventions have strong evidence support. These interventions save lives, help people stay safe, and then that really is the foundation for the therapeutic work. So let's consider how now we may think about bringing a harm reduction therapy orientation or therapeutic services into these harm reduction settings so that the public health harm reduction interventions may be the kind of point of contact around which people make contact with healthcare, with helping professions. And then we can wrap therapeutic services around them to engage folks in addressing the full range of needs and making positive change in all of those areas. So maybe at this point I can stop for a moment and check in with folks. Questions about kind of the basic harm reduction principles or these public health applications. Are there any questions that we should address at this point?
Hi, Dr. Tatarsky. We had one question come in during the first part of the webinar. Someone asked, can you speak to evaluations of programs based on harm reduction? What behaviors are used as an indicator measure, for example? Can you reference any studies, not referring to measures of disease transmission related to syringe exchange, but rather the process of change related to risky behavior?
What a great question. Unfortunately, until recently, the federal government was not supporting funding for research for anything that had the term harm reduction in it. So while there are a growing number of programs around the country, my Center for Optimal Living, places in San Francisco, in Chicago, in Washington, D.C., and a number of organizations that I've actually trained, there has been no money for rigorous, controlled research on outcomes. But just a brief answer to the question of how we might be evaluating, and we're doing this in-house, looking at our outcomes, is that, the traditional abstinence-only model was really assessing success according to rates of abstinence. But when we shift to the harm reduction lens, now we can assess on a whole grid of variables, all of which impact on problematic substance use or other problematic behaviors. So yes, we evaluate reductions in substance use. We evaluate attendance, active participation in treatment, ability to engage effectively in therapeutic alliance. But we're also looking at all of the other areas of functioning in people's lives, including health, relationships, vocation, criminality, etc. So we can really track positive change in this kind of gradual, incremental, stepwise fashion. And I mean, there are some studies that have looked at, some very large studies that have looked at how even incremental reductions in intensity of substance use has contributed to dramatic increases in health and other factors such as that.
Okay, we do have a few more questions. So someone did ask, is there a point where harm reduction services turns into enabling behavior?
Um, what a wonderful question, which I get in just about every talk that I give. Um, some people who are in the harm reduction world say that harm reduction enables people to stay alive. So, you know, that question of when does helping help and when does helping hurt is really at the core of harm reduction practice, and certainly harm reduction psychotherapy, what we're doing. In the old days, if you were using, you could not be in treatment. That's what the abstinence-only approach did. You had to make a commitment to stop. You had to stop pretty quickly, or else you couldn't be in treatment. The harm reduction framework opens the door to this large group of folks that are not yet ready to stop. And so we have the opportunity to engage people in beginning a process of positive change. Then the question is that you raise, which I think is really important. Um, how do we assess that what we're doing together with folks is actually helping people move in a positive direction and not simply supporting risky and problematic behavior, which might be one way to think about enabling? And so I think we can evaluate that actually relative to the prior question, which is by really evaluating objectively, what seems to be happening? Can we objectively observe positive change? Is is the person meaningfully engaged in an active way in their treatment? What's the quality of the relationship, the quality of the alliance, um, the quality of motivation? Um, but I think there's also, and this is where it gets murky because it really has much more to do now with our clinical judgment. And let's think about analogous risky behavior like suicidality. You know, we see many people in treatment who are suicidal, and we see them in outpatient psychotherapy. But we have to continually evaluate the level of risk, the level of engagement, right, in order to determine whether this is a viable therapy or whether this person is at too great a risk. And we then need to address that risk, see if we can make a change, or refer to a higher level of care. I think the same is true when we're talking about active drug use. So it's really about kind of evaluating risk, evaluating motivation, objectively, and also in terms of our clinical judgment, which is really where, the challenge is in moving into becoming a harm reduction therapist. There are a lot of challenges inherent in that, how you do that, which hopefully we'll get to talk about a little bit toward the second half of today.
Okay, so we have had a few more questions come in. Maybe we could do two more and then move on.
Okay.
Does that sound good? Someone asked, I would like to know helpful models communities could use to address primary prevention for kids from a harm reduction perspective in families.
Mm. Well, excuse me. There is one wonderful program, which is a parent education program for parents around their children's drug use. And it's a program called Safety First, which has a website you can look at. They have materials and so on. And what they speak to is the parent or the teacher's concerns that when my child is using drugs, particularly adolescents and young adults, how do I intervene if I, don't want to get heavy-handed? What does intervention look like from a harm reduction perspective? And that's a program that has been adopted by a number of PTA associations around the country, and essentially it gives some guidance to parents about the importance of getting educated about risk, about having honest conversations with kids, about keeping the communication and the relationship open and mutually supportive, and that parents really have a right and responsibility to let their kids know about their concerns. but also recognizing that, parents and all, we are limited in what we can do to protect or prevent. And so there's then a set of guidelines, harm reduction guidelines and education that we want to give to kids or young people about how they can potentially keep themselves safe if they are going to be experimenting and putting themselves at risk. And I think the final recommendation is, if you're ever in a situation where you're in trouble of one sort or another, please call me day or night and I will be there, to help out. And then we can try to figure out what was happening there. But that's one very important resource. There's also another resource called CRAFT, Community Reinforcement and Family Treatment. Bob Myers came up with this as a program for concerned significant others that have a loved one that is struggling with drugs or alcohol who is not ready to go into treatment or to get help. And so it's really a very wonderful program for supporting concerned significant loved ones in how to interact with that loved one in such a way that is not going to, quote, enable or support negative behavior and will identify and reward positive behavior. So those are two resources that I would, suggest that you check into. Maybe
Okay.
we should move on at this point,
Okay, sure. Yep.
in the interest of time, and I will check back with more questions a little later. So I'd like us now to think together about challenges that are out there in addressing substance use. I mentioned stigma. I really believe that our culture is soaked in stigma. We have all of this language, junkie, addict, dirtbag, crackhead, drunk. The language kind of is soaked in negative associations, negative connotations. If we could ask this group to throw, your associations in the chat, I bet we'd hear things like loser, lowlife, selfish. I mean, it's just in the culture. And we need to think about how a culture of stigma lives within all of us, and how that affects how people who use drugs feel about themselves, how it affects the rest of the community who don't identify as people who use drugs, and how they feel about people who use drugs. I think as helping professionals or clinicians, we need to look at how that stigma lives within us in what I call a kind of social countertransference, which can really contaminate our ability to listen. Stigma creates shame and fear of punishment or rejection, which then can contribute to folks who need help, not seeking help. So that's a primary challenge that I think we all need to be mindful of. And then I think the criminal racist model, the war on people who use drugs, also is a model that is ubiquitous in our culture. And it's not just problematic because it incarcerates people who need help. It punishes people who could use help, but also because it creates a culture of fear, a culture that contributes to people feeling scared, feeling guilty, feeling ashamed, feeling like they need to hide out, worrying about being punished. And so we need to look at how the social context actually contributes to a lot of the problems that people who struggle with drugs and their families have. Now, the disease model, which I don't want to go into in too much depth, but I think that disease model has been the dominant model. And I believe that as a model, it is potentially very problematic because it suggests this kind of reductionistic understanding to biology, right? The drug affects vulnerable biology, gives rise to brain changes, which cause this addictive process. And I think that, as I will get to shortly, that what we call addiction is much more complex than that. And certainly biology is one of the threads of a psychobiosocial framework. But the disease model tends, or at least risks, reducing complexity to just biology and can actually reinforce a kind of avoidance of complex meanings. So let me just pose that as something to reflect on. Also, it can become a self-fulfilling prophecy. All of these narratives get internalized by people who use drugs, which can lead to a feeling of, I am no good, I am doomed, I have a disease, I'm sick, and it's a permanent thing that inevitably, will take control unless I commit to complete and total abstinence. So if people are not yet ready to commit to complete and total abstinence, that can contribute to a kind of self-fulfilling prophecy. So I find it very valuable and important to be constantly talking with people about how do these narratives live within you, within us, and how might they be problematic. This abstinence-only ethos, which arises from the disease model, kind of dominates our culture in that, high bar expectation that if you're in trouble, you need to stop. But what if people are not ready or able to stop? Then that ethos can be a setup for failure, both for the individual and for the loved ones. Why can't you stop? It's a problem. It's hurting our family. And I think we need a different way of understanding why people continue to use in spite of negative consequences. The abstinence requirement can be so limiting. If you're not ready or able, then you become the failure. And I think we as a society and we as a field need to really rethink, and this is what I did in my own process professionally, maybe there's something wrong with these assumptions that is actually contributing to the failure. These ideas have also contributed to a split between the addictions field and the mental health field, right? If addiction is a disease unto itself, you got to deal with that first, and then you can access mental health care. But if we have a different model, seeing addiction as being intertwined with complex personal and social issues, we then need to think about a more integrative way of thinking and intervening. And of course, and I'm going to say more about this too, addiction is often, if not usually, associated in one way or another with trauma, vulnerabilities in self-regulation, all sorts of other complex personal struggles. And all of these struggles really contribute to why people may be in pre-action stages of change. And I'll say more about that in a little bit. So this is what I think are our dominant challenges, that most problematic substance users are not willing to stop. Many people have different goals. That is, they may be willing to stop some drugs that they consider to be problematic, but not other drugs that they don't consider to be problematic. And of course, abstinence is not realistic for most addictive behaviors, sex, eating, shopping, internet, etc. So we need to have a way of understanding and intervening with this group of folks. I mentioned stages of change. Most of us now are familiar with this model, but I think it's really a valuable model to think about when we think about the major stumbling blocks to change for people that struggle with drugs and other risky behaviors. Petraska, Norcross, and DiClemente did a massive study of positive or successful self-changers. And in studying lots of people, they came up with this model. And basically what they discovered was that people go through a number of stages before they get to the point where they're ready to take action around positive change. In the pre-contemplation phase, people don't identify a problem, so they're not thinking about making a change. Many of them may not have problems. Many of them may have problems, but they haven't yet made the connection. So at that stage, our job may be to help people sort out, do I have a problem or not? And help people self-assess in a way. Now, once people have identified that something about their use is problematic, they move into a contemplation phase, and there's a lot to contemplate. What is the nature of my problem? Do I need to make a change? what is my problem related to? Is it just, the substance? Is it related to other issues? Um, what positive change goals might I think about making? What are the barriers to thinking about change? Now, once we've sorted all of that out and people are clear about a goal and feel motivated, we now move into preparation, which is there's a lot to think about to prepare for change. Do I need treatment or not? Can I do it on my own? Do I need to involve my family? Is it inpatient, outpatient? What approach to treatment? Who do I need to bring on board? Right? So there's a whole lot of stuff that goes on before people are ready, motivated, and able to take action around change. And I think that those folks that I talked about at first, Peter and Valerie, are in this large category of pre-action stages of change that I think most people who struggle with drugs are. Now, just to contextualize that more broadly, these folks they looked at people who were groups of people engaging in 15 different high-risk behaviors. And they found that at any point in time, over 80% of people in each of these groups were not ready to change. And so what that does for me is it really contextualizes that people that are not ready to change their drug use or address addictive behaviors are probably about in the same percentage as people who are engaging in every other risk behavior, which is interesting to think about the implications of that. Are those folks any different from the rest of the community? The folks that are not exercising, that are not eating healthily, that are overworking, that are engaging in all sorts of other risky behavior? And are the dynamics and the issues fundamentally different, or are they really universal to human beings? This is another thing that I think is interesting to think about in terms of the critique of the disease model. Most people that use drugs are not using in problematic ways, as you can see here. Some people then veer into mild, moderate, or severe substance use disorder. The data shows, though, that a majority of people that veer into substance use disorder essentially recover on their own without treatment. So I think that is one of the fundamental challenges to the idea of the disease model. That is, this is a, quote, disease that actually people can cure on their own or that remits on its own. It doesn't follow the trajectory of other biological diseases that need treatment. However, there are some people who need and want treatment because of the severity of their use and are motivated to seek it out. And those are the people that harm reduction psychotherapy is speaking to. So I want to begin to talk about this other model, what I call the multiple meanings model. If we shift from disease and biology to meaning, we might consider that what we call addiction or problematic substance use may carry or express multiple meanings simultaneously, could mean many different things at the same time, and that these meanings are on a spectrum of awareness. That is, some people know why they're using. I feel bored, I feel anxious, I feel restless, I want to feel better, I'm unhappy. Other folks actually don't know why they're using. They're mystified. They feel an urge, and then they give into the urge. And with this group of people, we may be thinking about dissociated meaning, that is, motives, needs, feelings, parts of the self that are out of awareness, which may be related to trauma. And in that case, we might think about the problematic behavior as almost a language that people are speaking in action through, rather than being able to symbolize their experience in words and communicate it directly. So we might think about, well, what is this behavior containing? What meaning is it containing? And what is it expressing? And now we might wonder, what are all of the reasons that people use drugs? And I'm going to go through lots of possibilities, and there could be more which, we could spend, months or years studying. But certainly people use drugs for fun, pleasure, liberation, self-care. And that might become more of a compelling motive for people when their opportunities for pleasure, liberation, etc., are limited, such as during the pandemic. I think our opportunities for fun, pleasure, recreation, self-care have been severely limited. And of course, we've seen an increase, a dramatic increase in drug use, alcohol use, and overdose. Now, we may also think about how drug use, the addictive relationship, may have relational meaning. That is, think about why somebody turns to a drug rather than turning to people. And that may have very deep roots in relational conflicts, that is, conflicts about dependency, conflicts about expressing one's needs in primary relationships. Now, self-medication is an idea that has really gotten out into the culture, and I think many people really feel that as meaningful. That is, using to medicate or to manage suffering, distress, depression, anxiety, etc. And it's an attempt really to cope, attempt to feel better. Now, given that relational meaning I mentioned, the drug might be an actual way of expressing something interpersonally that people have trouble expressing in words or directly. If I feel angry and I really feel conflicted about expressing my anger, I can maybe use a drug in a way that, that retaliates, a kind of a getting high as a way of retaliating or expressing that anger to hurt you. Trauma is very often at the heart of problematic substance use. There's all sorts of data about this. We might think about trauma having lots of symptoms or lots of consequences for the individual, all of which can render people vulnerable to turning to a substance to manage, to medicate, to care for those trauma symptoms. I'll get back to the rebellion against the critical inner critic, but expressing dissociated parts is one of the ways that substance use might express, the consequences of trauma. The anger that I wasn't able to express, I can express in using, or the grief, or the sexuality that I wasn't allowed to express, I can reconnect with while I'm using substances. Self and affect regulation, that is feeling flooded by feelings, feeling overwhelmed, is also a consequence of trauma, and using drugs can be a way to try to turn down the intensity, to kind of cope with that experience. Shame and guilt are often also consequences of trauma. And shame and guilt actually can cause people to use substances as a way to try to calm the shame, calm the guilt. But also feeling guilty and ashamed about using can propel people to use more. So it can be a really interesting trap that people get caught in. The identity integrator I alluded to, this idea that by using a substance, you may be able to reconnect with parts of yourself that you disconnected from because of traumatic experiences, the anger, the dependency, the sadness, etc. If we move over to the right, the rebellion against the inner critic, many problematic drug users have very harsh, punitive inner critics that create, anxiety and guilt and shame. And getting high can be a way of temporarily putting the critic to sleep. So you can have a brief feeling of, freedom to relax, to be yourself. Body needs, pain, fatigue, enhancing performance, bonding, group membership. So we might think about what are the multiple meanings that may be operating in one's relationship to drugs for this given individual. And to the extent that this is going on, that the addictive relationship is expressing something and it's disguising it, and it's disguising dissociated parts of the self. To the extent that that is going on, the problem behavior or the urges to engage in the problem behavior, we could think of as entry points for rediscovering, exploring and rediscovering and reconnecting with those disowned parts of the self. As we can identify them and help people name them, put them into words, and bring them into our therapeutic relationship or bring them into their lives, we could think about that as being, a process of recovery, recovering those lost parts of the self and learning to integrate them and bring them into their lives in a more, in a healthier, more self-affirming way. And we can ask things like, what part of you wants to do this? If the urge could speak, what might it say? There's a lot more we can say about that process of discovery and reintegration. But we also need to think about habit. To the extent that I engage in this behavior and I find it helpful as a coping mechanism, over time, engaging in this thousands of times, it becomes a deeply ingrained habit, an overlearned habit. Stimulus, response, reinforcement. I feel anxious, I have a drink, I feel better. If you do that 1,000 times, not just the drinking, but the urge to drink becomes, powerfully conditioned. When I feel anxious, I want to drink. When I think about going into a place where I may feel anxious, I want to drink. Now, to the extent that that urge is what is driving the problematic behavior, imagine we could stop the action around the urge, sit with the urge, and think about, is this the best, most self-affirming choice? Or might I make another choice that is actually healthier or more in line with my values? So then we could think about that urge as the potential axis of positive change. So a therapeutic process will be about helping people identify their urges, cultivate the skills and capacities to sit still with their urges, to think about alternatives, and to work in a new repertoire of caring for oneself. And these habits actually locate themselves in neural networks that get set up, which is another way to think about why addictive habits or behavior is so hard to change. Through neural plasticity, habits become networked up. The good news, though, is that if we can disrupt those habits through urge surfing or sitting with the urge and think about through repetition, wiring in a new repertoire for responding to those triggers, to those feelings, over time, we can rewire our brains. We can wire in a whole new repertoire as an alternative, more effective way of caring for ourselves than that addictive response. And finally, the social context. I mentioned the legal context, criminalization. If that contributes to people hiding out or incarcerating them, cuts them off from sources of positive social support, that's going to increase feelings of shame, guilt, anxiety, despair, all of which are likely to increase people's distress and increase their drug use, if that's where they go to when they use drugs. Bruce Alexander came up with a theory of social dislocation to explain why cutting people off from sources of positive social support only makes things worse. And that if we can actually bring folks that are struggling into increasing their positive support network, that's going to decrease a lot of these negative feelings, increase people's feelings of hope. And that may be one way to understand part of how 12-step programs, recovery programs really work. They invite people into a positive support system without requiring that they stop, so that they can reconnect with others. And then that can be the foundation for a whole positive change process. So if we put all of those factors together, we might say that this is the psychobiosocial framework. In the top left circle, we've got all of these factors that we can consider as vulnerabilities. That is, they don't cause addiction, but they may render people vulnerable to turning to the substance or the other addictive activity. And if it works in some way, it's pleasurable, it reduces distress, it becomes reinforcing. Uh, it may explain why people who use continue to use. Now, as you use over time, chronically, a whole set of negative consequences may kick in, changes in brain receptors and brain chemicals, changes in health, changes in emotional functioning, impact on relationships, as well as the feelings of using in a criminalized and stigmatized culture, all of which can contribute to greater distress and greater tendency to use substances. So that can really be a way to understand that vicious cycle of addiction. There are all of these complex factors in motion. But I think what we also get from this model is an understanding of why people may continue to use, even feel they love using, when it becomes increasingly problematic. And that is a way to understand that dilemma that Valerie and Peter were caught in. What this model also suggests is that any one of these variables, these factors that may be operating in this process, that somebody is motivated to come in to get some help with, could be a point of engagement. If people come in for their trauma, for their homelessness, for their medical status, for their relationship issues, even if they're not ready to begin working on the substance, we can join them around the issues that they're motivated to work on. And that can become the basis of a therapeutic healing relationship, which over time then can broaden as we do our assessment to identify and address all of the other issues that may be operating here. And a positive change in any one of these variables is likely to change a person's relationship or motivation for the substance. If I feel less depressed, I may feel less compelled to use the substance as a form of antidepressant, for example. If I feel more hopeful because I'm now connected to a community of support, I may feel less despairing and less compelled to use a substance. So this is the model that I've created really as an application of harm reduction principles to psychotherapy. Psychotherapy counseling, we can broaden it to any helping relationship. I want to talk briefly through these 7 tasks, and then I want to touch on a few therapeutic interventions. And I want to leave 10 minutes at the end for some Q&A and discussion. So let's consider that for me, the most direct therapeutic expression of the harm reduction principles of starting where people are, working with them collaboratively, is an emphasis on managing the therapeutic alliance. That is initial engagement, but also keeping people engaged throughout. And so, we might think about what are the challenges to initial engagement with people that have multiple histories of trauma, that have a complex array of issues. And I think one of the primary things that roadblocks is that people are not ready to stop rather, and they may be anticipating that we have expectations of them that they can't possibly meet. So one of the first ways of setting the stage for a harm reduction therapy is really making it clear to people that we will invite them into therapy without having expectations about stopping, or without really having any expectations or agendas except to be helpful to them on their terms. And offering that stance can just be dramatically inspiring to people who were not motivated for therapy, who then become motivated. Now think about meeting people where they are. The essence of therapeutic alliance is an alliance around goals, tasks, and the quality of the bond. So the challenge is really on the provider to find a way to offer something to that individual that meets them around goals and motivations that they find meaningful. How do we offer people something that feels relevant to their needs? Now, once we've got some initial alliance going, we create a relationship. And I think the relationship itself can be an agent of healing in so many ways. But certainly around the shame and guilt around the substance, when we invite people in with their substance use, and rather than being punitive and critical and judgmental, we say, hey, I'm curious about your use. In fact, I might even respect that you must be using for very important reasons that I'm curious about, and I'd like to hear more about. In the therapeutic work, some people think that one of the major agents of change is a new corrective emotional experience. And so I think that the harm reduction frame can actually offer people a corrective emotional experience around their substance use, and then also to invite the exploration into the meanings, the multiple meanings, the parts of the self that are kind of living within that substance use, that people have also felt were unwanted. And as we invite the exploration, we can also invite people to bring those parts of themselves into the therapy and have a new experience of being met with respect, with empathy, with support, which I think can promote healing and integration. Now, the third task is that to the extent that people have difficulty regulating their emotions, regulating themselves, often as a result of trauma, it can be a setup often to ask people to change the behavior that is a response to self-regulation difficulties before we've actually shored up their capacities to self-regulate. So we can do this implicitly in our empathic therapeutic relationship. We support people in becoming better at self-regulating in that way, but we can also support self-regulation and self-management very actively in teaching skills such as mindfulness, such as breathing techniques, such as positive self-talk, cognitive self-talk. That is a whole array of skills that people can use to manage to sit with distress in a more effective way, to sit still. When people now have a greater capacity to sit still with their urges and the distress related to it, we can now put our heads together to do what we call assessment as treatment. It becomes possible then to look at, begin to tease apart the psychobiosocial factors, the multiple meanings of the substance use. And as we can unwrap all of that, we now can see more clearly why people are ambivalent about change. And the fifth task is that we want to embrace ambivalence. We want to embrace both parts of the person, the part that wants to change or wants to stop, but we also want to invite the part that wants to use or is in love with that substance or that experience into the room. Most people have the experience of a battle, right, between the good me and the bad me, the angel, the devil, the part of me that wants to change, the part of me that wants to use. But if we can invite both parts in and embrace and meet each one with respect and empathy, we may actually be able to encourage a more constructive dialogue and exploration about what would be some changes on the using side that would actually support the part that wants to cut back or stop. So for example, if I'm using to deal with anxiety, if I could develop other more effective ways of managing my anxiety, I may be more motivated and feel ready and able to cut back or to stop the substance use. So working with ambivalence, we can now come up with positive change goals, which is the sixth task, positive change goal around the side that's using, manage my anxiety more effectively in other ways. And then that can support change goals around the problematic substance use, kind of cutting down, using less often, using more safely, maybe even doing an abstinence experiment. Now, once we've got those change goals on both sides, now we can put together a comprehensive plan for positive change. building in a whole set of, therapeutic techniques, involving the family, involving relationships, involving medical and psychiatric providers, having people get involved in group support, etc. But you see, so when we begin with goals and a treatment plan before we've done all of this previous work, that can really be a setup for failure. When we begin with therapeutic alliance, working the relationship, strengthening people's ability to sit still with distress, collaboratively assessing the complexity of these behaviors, working with ambivalence, we can now then set the stage for goal setting and action around change. So this will really support people in moving through those stages of change we mentioned before. Managing the therapeutic alliance, the first task, just want to say a few things about this, and that is that we've identified 4 engagement skills. I think about this almost as a harm reduction listening stance. Empathic listening. What is starting where the person is in a therapeutic context, if not really listening for the other person's experience? The empathic stance is really trying to understand kind of what is this person thinking? What are they feeling? What are they struggling with? What are they bringing to me? So the opening gambit in a harm reduction therapy is, how can I be helpful to you? And as the person shares with us what brings them, our harm reduction stance is to really try to put our own agendas and countertransference to the side and simply listen, right? And as things arise that are unclear to us, we want to then invite a collaborative inquiry, which is more about clarification. Tell me more about that. I'm not clear I understand what you mean. And when we feel like we've got a real clear understanding of where the person is motivationally, in terms of their struggles, in terms of what they're wanting from the process, we can then do an empathic reflection, which is to reflect back. I think this is what I'm hearing you say, in terms of your feelings, your thoughts, your goals, your motivation, the things you're struggling with. And then the check-in, did I get it right? Am I on target? Does that resonate with you? When the participant, the client, the patient can say, yeah, I feel really understood. I feel like you're getting it. Now we're in alliance. So think about those 4 engagement skills as skills that we can continually use throughout the course of our work together to try to stay in alliance. And if there's a rupture, if there's a feeling that we're not doing so well, checking in, am I getting something? Am I missing something? So I think that can really guide the entire process and set the stage for everything else that we might do together. Of course, managing countertransference, that is our feelings in relation to the people that we're trying to be helpful to, is a key to all of that, because our feelings can be both a guide to understanding. Our empathic feeling of sadness may be a clue that the person is feeling sad, but they can also get in the way. They can blind us. So we need to be constantly on top of our own feelings. And a particularly important one is what I call social countertransference, our own internalization of those narratives of stigma, of disease, of criminal, that actually can live within us and serve as blinders to being able to really listen to that person. So empathic listening and reflection is really grounded in a commitment to really examining our own experience and trying to be on top of it, to clear a space to really listen to the other. And finally, in terms of this engagement piece, as we're listening for the story around the substance use, and we begin to hear the psychobiosocial factors and the multiple meanings, and reflect that back to people, this is what I'm hearing about the function, about the meaning, about the circumstances, etc. We can then reflect back a psychobiosocial formulation, or like a theory of what people are struggling with. And when people really resonate with that and they say, yeah, I get that resonates with my experience, that becomes then another basis for therapeutic alliance, and it really sets the stage for all of our therapeutic interventions, which are going to really emerge from or be guided by that formulation. So we've got 6 more therapeutic tasks that we don't have time right now to really get into. I've touched on them in the last slide. But if really folks are interested in learning more about this, I've given a number of publications to the organizers that you can refer to, some writings that really describe the model in a lot more depth. And also at the Center for Optimal Living, we do periodic level 1 trainings, which are like the basic training. We have a level 2 training, which goes into all of this in a lot more depth. And certainly if you're interested, check out our website. You can always reach out to me, and I'm glad to have conversations. At this point, maybe we can open it up to the group for questions and commentary.
Sure. So we did have some more questions come in. Let's start with, if someone is significantly struggling to stay sober and sobriety is their goal, and they are experiencing great guilt and shame over their many relapses, do you ever introduce the topic of exploring harm reduction when that is not the client's original goal? Do you have pointers on ethics in this situation?
It's a really complicated question because a harm reduction approach, think about it, meeting people where they are. If people come in with an abstinence goal, we're going to meet people there. So again, going back to what I said at the beginning, it's not harm reduction or abstinence. Harm reduction, think about what I just said about engagement, starting where people are. We want to meet people around wherever they're motivated to go. So if people are committed to an abstinence goal, that's where we're going to be working. Now, there is a question about whether that's, then the question comes up, why are they struggling to maintain abstinence? Or what is the struggle about to, to successfully achieve and maintain abstinence? And I think that this model is entirely appropriate, because if we can support creating a safe space to really look at, people's urges, when you are committed, so let me make one comment that about the personalized plan for change. We use a technique which I think is applicable to whatever positive change goal. We call it the ideal use plan. So it's a provocative concept, right? But we ask people, how would you ideally like substances in your life in a way that would maximize the benefits and minimize the costs? And it's a technique for really challenging people to think through, how do I want substances in my life? And then the question is, what would that actually look like in terms of your use pattern? And what other issues would you need to address in order to support you effectively achieving that ideal relationship to drugs? So in this case, if somebody's goal is abstinence, let's say that their ideal use plan is not using, right? But what that ideal use plan then does is it gives us something that we can now work together to examine, what kicks up that is in conflict with that use plan. So people have urges to use. Let's see if we can stop the action around the urge with a technique that we call urge surfing, that is bringing mindful awareness and breathing techniques to sit with the urge and reflect on, what is this urge about? Is it about anxiety? Is it about control? Is it about autonomy? Is it about desperation? So whatever the ideal use plan is likely to be in conflict with people's problematic use, and being able to kind of stop the action when people have urges to act in ways that are in conflict with their ideal use becomes an opportunity for that exploration and clarification of the issues that are embedded in the problematic use. And then that can open up work to address those issues in various ways that will then support the person's ideal goal. Sometimes people discover the reason that they can't successfully achieve abstinence is because there's a part of them that is really not committed to abstinence. And if we don't take that part seriously and really dig into, what part of you does not want to stop and why, if we don't invite that part into the room to really take it seriously, that part can continue to subvert the abstinence plan. So it may be, like with Valerie or Peter, in both cases, the part of them that was using in love with use was a traumatized part. And what we needed to do was have a real ongoing deep exploration of histories of trauma and get some traction in resolving some of the trauma symptoms before these folks were able to and did very successfully commit to abstinence.
Okay, thank you for that answer.
Yeah.
Another question that we have is, in using this model, how do you respond with individuals who are in the criminal justice system who are expected to not use per their court order and they are in treatment for their use? As a therapist, this, meaning harm reduction, makes sense, but the court may disagree.
Another really wonderful question that's, on the ground, and it's something that we confront all the time. Let's think about all of the mandates, right? Court ordered, spouse ordered, family ordered, school ordered. There are all of these forces that may order or mandate people to treatment with certain guidelines and expectations. Some of which may be completely unrealistic. Some of which may be helpful or maybe were necessary, to motivate somebody to get in. But the first comment I want to make is that I think that when I talked about the systemic stigma or the criminalization as problematic, is that a lot of these systems have, I think, inappropriately taken charge of treatment decisions, which should really be, as any health, service decision, be between the patient and the provider. So we've got these external systems, which are not mental health folks, that are dictating terms that may really be counter-therapeutic. So for that reason, I think that we helping professionals may see ourselves often in a position of educating, of consulting, of having to take on these systems to help them understand and kind of evolve. And many of them are. There are many places where the POs and the judges are kind of listening to treatment providers and engaged. That's number one. But number two is, if we think about this harm reduction approach as helping people to make their healthiest, reasonable choices around their health and their well-being and that of their families and their communities. One of the harms associated with problematic drugs is the potential to have a fentanyl contaminated drug that will kill you. So we want to help people navigate their decision making around whether to use, given that risk or not. Another one of the harms in this case is, if you use, you may put your liberty at risk. So we don't have to come down on the side of the mandate or even take a value position about drug use, but we can come down on the side of wanting to help people make their healthiest, most considered choices, identifying risk and making decisions to reduce risk. And then once people have made those decisions, like let's say in this case, a person realizes, I don't want to stop. I don't think I have to stop. But if I continue using, I may get reincarcerated. And so thinking all of that through may lead to a commitment to abstain. But then going back to the prior questioner, given if a person has this long-standing, habitual problematic pattern of use, even a commitment to abstain is going to or will require that we do a lot of work on helping people unpack their vulnerability to use so that we can address those issues in a way that will support an abstinence commitment.
All right, thanks for that answer.
Hmm?
All right, let's see. Could you speak to the idea of cutting back with patients who have loss of control as part of their picture of addiction? What has been your experience with patients' ability to successfully cut back? What techniques have you used to facilitate or support this?
Mm-hmm. So um, there's so much we could say, and I really hope that if people are really interested in this, you may consider doing some of the reading that I've made available or join some of our trainings because there's lots of techniques. But um, consider that if I said before, the urge to use, which people don't have skills to sit still with. And so they feel overwhelmed by the urge and they move into action, right? That can contribute to overuse or excessive use. Um, Developing the capacity to identify an urge, feeling it in your body, feeling it in your mouth. The patient the other day said to me, when she thinks about alcohol, she literally salivates. She can feel this kind of hunger. Um, and so we've been working on, first of all, clearing away the shame and guilt that she feels about wanting to drink. That shame and guilt is often a barrier. And we've been working on her developing an ability to observe her urge, feel it, and sit with it, bringing mindful, curious awareness and breathing with the urge. That's urge surfing. Practicing urge surfing actually strengthens people's capacity to sit still. Mindfulness strengthens affect tolerance, tolerating distress. So we've been working on practicing being able to tolerate or urge surf for longer and longer periods of time. So now what she's been able to do is identify her, moving from excessive drinking to implementing a 2-drink minimum spread over 3 hours in the evening, and implementing that by bringing her urge surfing technique to the implementation of the 2-drink over 3 hours plan. And as she feels urges to overdrink, to engage in that third drink, she's surfing them, sitting still with them, and then also she's doing a lot of other things, like rather than having the third glass of wine, she has a glass of water or seltzer. Um, so if we think that back to the idea that the excessive pattern was deeply wired in as a habit over many years, bringing the urge surfing to implementing the new habit is really about working in a new pattern, like we work in any complex behavior change, right? And now she's begun practicing this new pattern, and it's becoming more and more second nature for her. And we could apply a version of that model to any excessive pattern and any positive change pattern that people attempt to implement.
All right. Do you want to do one more question or because we're
Sure.
almost, I guess it is 4 o'clock exactly. So,
Well, I'm open to maybe taking one or two more.
all right, let's do one more. Um, could you comment on the application of IHRP in a group setting such as recovery sober houses or other congregate settings?
I love that question because one of the things that we've done at the Center for Optimal Living is really a home for IHRP. Um, and it began primarily as an individual therapy model, but we've extended it to group therapy. We now, at my center, we have 12 harm reduction groups running for men, for women, mixed young people, old people, mixed genders. We've got uh, a skills groups and process groups. So I think the harm reduction IHRP in groups is really a very exciting shift. And we might think about harm reduction in groups really as, inviting people with different goals into the same group and even different stages of change. I think it's a little tough mixing pre-contemplation with everybody else, but sometimes it works. But let's say we get people in contemplation, people in preparation, and people in action are all in the same group, and some of them have abstinence goals, and some of them have moderation or safer use goals. Or in contemplation, some of them are trying to figure out what their goals are. So we've got a very diverse group of people, but what bonds everybody is that they're all there motivated for positive change. And so rather than segregating people by goal, an abstinence group, a moderation group, a harm reduction group, we think that the mixed goals group really is a very powerful supportive way of working, because in practice, people rarely just commit to a goal and achieve it and stick to it. More likely, the change process is a process of doing different experiments. So people may do abstinence experiments or moderation experiments, or even in the stages of change. The idea was that you might relapse or quote, go back to an earlier behavior, and that's really, we think, more likely how people change, 2 steps forward, 1 step back. So the harm reduction group enables people to have a very strong connection to a peer group and to be able to stay with that group as they're going through the different attempts, the different experiments, and learning from one another, about abstinence. One example, powerful example, comes to mind. I was running a men's group, and there was a senior gentleman in his mid-70s who came in to the group with a long history of problematic drinking. And he came in drinking, and he wasn't sure what he wanted to do. In that group was a man with 2 years of abstinence. And the man with 2 years of abstinence was just talking about how great he felt, how good he felt about abstaining and not using drugs. And this older man was so impressed by this young guy, he said, "I want what you have." So the next week he came in and we said, "Hey, how you doing?" He said, "I haven't had a drink since last week." We were kind of surprised since that hadn't been his goal. And we said, "Why?" And he said, "Well, I told you, this young guy was so impressive to me. I wanted what he had. And so I felt really inspired and motivated to, do an abstinence experiment and see how it goes." So I think that those, harm reduction groups can be integrated into different settings. Unfortunately, we're just about out of time, but I think that this harm reduction framework can really be integrated into many different settings, including abstinence-based settings, like a rehab where you need to stop. But we can still create this therapeutic space which is really designed to support people in getting clearer about, what their ideal goals are and what approach to change may make sense to them. So when they get out of whatever the situation is, they're prepared, they're armed, and they can, kind of move into another setting to support their next steps.
All right. Unfortunately, that is all the time we have for today. Thank you so much, Dr. Tatarsky, for this wonderful webinar. We're getting all kinds of positive comments in the chat. I've placed the Center for Optimal Living link in the chat box for anyone who is interested in looking further. There's a lot of great training and events posted on that page. So go ahead and take a look at that. And I'm just going to wrap up here with a few more housekeeping items. We would like to remind all participants that a recording of today's presentation will be uploaded to the webinar library located on IREDA's website by early next week. Once we have the recording posted, a link will be sent to all of today's webinar registrants. I now want to remind you of our evaluation and CEU process. You will receive several follow-up emails from us. The first email will include a link to the evaluation, and the second email will include step-by-step instructions on how to obtain CEUs. Please note that it will take up to 48 hours for your CEUs to become available because we have to cross-check your attendance records. We would like to specially request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate today, and thank Dr. Tatarsky again. If you have any questions, please feel free to email us. Our email address is info@ireta.org. And with that, I will conclude the webinar. Thank you so much and have a wonderful afternoon.
Thank you so much, and thank everyone for joining.
Thank you. Bye, everyone.
Bye-bye.